At the microscopic level, dyspareunia, or persistent genital pain during intercourse, looks like this: cellular mucosal bonds stretching to their limit and physically tearing apart under lateral shear force. This cellular failure is frequently misidentified as general soreness or a lack of psychological arousal, but the pathology is a precise mechanical breakdown of the tissue structure. The tissue in question is the vaginal squamous epithelium, a multi-layered lining designed to withstand significant physical pressure. This resilience is contingent on a low coefficient of friction. When friction levels rise, the tissue's defensive properties are overwhelmed. Without a lubricating barrier, shear force drags across the epithelium, creating lacerations in the mucosal bed. These micro-injuries represent a deviation from healthy physiological function, rather than a baseline byproduct of intimacy. The appearance of these tears indicates a failure in the specific biological cascade intended to protect the body during arousal. Preventing this friction requires the synchronized coordination of three systems: hemodynamics, endocrinology, and the autonomic nervous system. By reverse engineering these injuries and tracing the biological sequence backward, we can identify exactly where the protective mechanism failed. This recurring pain functions as a mechanical alarm bell, signaling a breakdown in the systemic or behavioral requirements for safe movement. Understanding the failure requires mapping the macroscopic architecture of the mucosal wall and the dense capillary beds situated just beneath the epithelial surface. In a healthy state, arousal triggers parasympathetic nerve signals, initiating the body's physical preparation for contact. These signals trigger vasocongestion. As seen in this cross-section, the capillary beds expand and fill with blood, creating a localized pooling of fluid in the pelvic region. This influx of blood increases the local vascular pressure against the epithelial walls. This pressure drives transudation, a process that forces blood plasma to seep through the vaginal epithelium and onto the surface. Simultaneously, the Bartholins and vestibular glands activate, contributing additional secretions to the mucosal surface. These combined secretions produce a smooth, elastic boundary layer that physically shields the underlying tissue. This specific fluid dynamic lowers the coefficient of friction, allowing for movement without cellular disruption. Without this cascade of vasocongestion and transudation, the physical barrier to prevent tissue damage is absent. When the fluid barrier fails, the dry mucosal surface is exposed to friction. We must look at the systemic factors that halt this production. The first category involves endocrinological crashes, where hormone levels fall below the threshold for tissue health. This graph illustrates the impact of estrogen on mucosal health. Estrogen maintains the thickness and vascularity of the lining. When levels drop, the structural thickness shrinks and capillary density decreases. These drops occur most frequently during menopause and the postpartum period, particularly while breastfeeding. Beyond hormonal cycles, certain pathological conditions can actively disrupt the lubrication process. Conditions such as Sjogren's syndrome or diabetes impair glandular function, reducing the body's ability to maintain systemic hydration and mucosal moisture. Iatrogenic or medication-induced disruptors are perhaps the most common hidden variables. This split screen shows how pharmaceutical structures on the left correlate with the desiccated tissue surface on the right. Common antihistamines illustrate this effect. While they are designed to dry out the sinus mucosa, they exert the same drying effect on the vaginal mucosa. Many SSRI antidepressants inhibit the specific neurotransmitters required to signal the pelvic region to begin vasocongestion. In these cases, systemic chemical imbalances override the nervous system, preventing the protective fluid response even when local sensory stimulation is present. If the endocrine system and medications are not the cause, we must examine the flow of sensory data to the brain. We must address the behavioral bottleneck that frequently bypasses the body's physiological requirements. This critical bottleneck is an insufficient duration of sensory stimulation, often referred to as a lack of foreplay. The brain requires a consistent influx of sensory data to authorize the parasympathetic signals that trigger fluid production. This creates a timing mismatch. A person can feel psychologically ready while the tissue remains in an unaroused, unprepared state. The hemodynamics of vasocongestion and transudation operate on a specific biological time delay that cannot be skipped. Initiating intercourse before this time delay has passed forces mechanical movement against an unlubricated surface. The result is a high-friction environment that the tissue is not equipped to handle. Rushing this neurological sequence leads directly to the microlacerations seen at the cellular level. Human anatomy is governed by biological patience. Bypassing the required neurological windup leads to physical trauma. Returning to the microscopic view, we see the consequences of unaddressed microtears. These tears lead to localized inflammation, which increases tissue sensitivity and soreness. This inflammation can alter the vaginal pH, creating an environment where secondary infections can more easily take hold. This triggers a neurological mevative feedback loop. As shown here, node A sends pain signals to the brain, which responds by sending inhibitory signals back down. The central nervous system registers this pain, subconsciously associating intimacy with tissue injury. In future encounters, this association triggers a sympathetic fight or flight response. This sympathetic response inhibits the parasympathetic signals needed for lubrication, ensuring that future attempts remain dry and painful. Breaking this loop requires a mechanical intervention, such as water-based lubricants. When spreading over the tissue, they fill in the microfissures and provide immediate protection. By acting as an artificial transiedate, these lubricants reduce shear force friction below the threshold of tissue damage. By removing the mechanical stimulus of pain, the brain stops receiving the trauma signals that trigger the fight-or-flight response. Over time, this allows the autonomic nervous system to decouple intimacy from injury, eventually restoring a baseline of healthy physiological response.